Hello, I'm Pansch. I'm a nurse practitioner practicing in Cincinnati, Ohio, and I work for Doc's Dermatology.
And I'm Shanna, Miranti, a dermatology PA from Naples, Florida. And it is such an incredible honor to be here with Leigh today. And it's been so nice to get to know you and to pick your brain and just to hear your perspectives on treating patients with atopic dermatitis. So let's talk a little bit about topical options. We now have so many exciting new therapies that are not steroids, which is so exciting. I treat a lot of kids and I love having available options that patients have never tried before. We now have a number of non-steroidal options in that space. We have, of course, Opzelura, which is topical ruxolitinib cream. We have roflumilast and soon to be FDA approved tapinarof. I think one of the obviously most burdensome symptoms of atopic dermatitis is itch. Itch is a 4-letter word. Patients want it better yesterday and they want it to be gone. So how do you counsel your patients with itch, and what exciting information do we have to share with them about their itch?
Well, I really think that it comes down to capturing itch scores. When I'm in clinic, I like to ask about peak pruritus NRS. 0 is no itch, 10 is the worst itch imaginable in the last week. And I also like to do in the last 24 hours. And I like to put PP-NRS 7 day and then PP-NRS 1 day. And then, or 24 hours, you could say. And you're gonna put their scores in, and that's a measurable piece of data that you can get a pretty good gauge on how well controlled is that itch, such a crucial symptom of this horrific disease that waxes and wanes. And really, quite frankly, batty, crazy, itchy is somewhere that none of us want to be. And so I was incredibly excited, like literally super excited to talk about the new itch data with topical ruxolitinib cream.
Absolutely.
Who knew? And you know, the bottom line is we get our patients for just a few minutes in our office. But do you want to talk about what the data said in terms of our itch scores? And then we can talk about applying that to our patient visits.
Absolutely. I love to, like you said, capture the itch scores and what they're feeling like today. But as we know, AD is such a, it's such a dynamic disease. It's constantly evolving. It's constantly changing, literally as the wind blows. And I'm in Florida where the hurricanes blow and stir up all kinds of AD craziness. So it's very good to get a knowledge of where they are today, because the skin can look great to us, but they can be so incredibly itchy. This is the itch that rashes. So when ruxolitinib's data came out with 15-minute reduction in itch data, I think a lot of us were very, very excited to be able to bring that back to our patients. So tell me how you kind of elaborate on that a little bit.
The wonderful thing about our friends at Insight is they do a phenomenal job providing patient samples. And so what I love to do when I have a patient who is batty, crazy, itchy in my office, I look at my MA with that look. She knows exactly what I need. She goes and she grabs a sample, she documents it in the record, and then I give it to the patient and I say, let's do this. I'm gonna keep you in this room. We're gonna put the clock on right now, go. I want you to put the cream on and we're gonna wait 15 minutes. And then I'm gonna come back and I'm gonna ask you about your itch in that specific area and if you've noticed improvement. And what the data shows is it works. And it's incredibly exciting to be able to offer our patients a tangible, very practical way to actually reduce their itch and overall improve their outcomes.
And you're getting to see real world tolerability. Are you hearing stinging and burning? Are you hearing complaints about, ouch, that hurts, you know, or anything else along that line?
I think that's really, really incredible. And I think it's genius that you just mentioned that, because quite frankly, remember, we're not talking about side effects of, say, steroid phobia or any of the other issues that can happen from chronic use of steroids. We're not talking about burning and stinging as with our TCIs or one of the older PDE4 inhibitors, topically speaking. We're talking about a medication that is very well tolerated, where they fixed the access issues in my neck of the woods. I don't have trouble getting it. And I've got a patient sample with your name on it. We're gonna get your itch better now, today, in my office.
And this is a compromised skin barrier we're talking about. So we are literally putting something on a skin that is cracked and excoriated, and water can even burn. So to hear that encouraging feedback that you're not seeing the stinging and burning, you're not hearing them scream from the other room, as they're applying something, that it actually may be helping make the patient feel better, that's incredibly encouraging. You mentioned access. Access is always such a difficult point, and it can be, a audible groan when you talk about this amongst other APPs. Everybody just gets incredibly frustrated with the prior authorization system. What tips and tricks have you instilled in your practice and in your documentation to help ruxolitinib get covered for AD?
Well, we already mentioned itch, and I think being that we have this new data, it's really worth mentioning, capturing itch in your note, however you do it. Like I said, I like to do 1 week and 24 hours. Additionally, what are the other prior trials and fails that you've tried? And
Right.
So topical corticosteroids, maybe they tried a TCI or a topical PDE4 inhibitor that actually burned, or they didn't care for it in some way or fashion, or they didn't feel like it really helped. These are the kinds of things that really you want to teach your MAs to ask.
Absolutely.
And then if you're not quite sure, ask those tough questions and get that data in your HPI so that you know what you have.
So we know that topical ruxolitinib can be used for 20% of a patient's BSA. So we want to make sure that we make that differentiating factor in our notes, that we are intending to treat up to 20% BSA. That's different from vitiligo, because non-segmental vitiligo, it is covered and FDA approved for up to 10% BSA. So for your AD patients 12 years of age and older, topical ruxolitinib cream can be utilized for 20% BSA. So making sure we document, maybe in our notes to pharmacists, that we are using this for atopic dermatitis, not eczema, not eczematous dermatitis, not eyelid dermatitis, not allergic contact dermatitis, not dermatitis unspecified. Use the words that are FDA approved. So use atopic dermatitis. And then if you have to put of the eyelids in a diagnosis comment or in your morphology, at least you have it documented as the FDA approved diagnosis. That's number one. Number two, make sure that we document the exact body surface area that we'll be using it on. Number three, make sure we are talking about tried and failed and capturing all of those particular topical therapies, systemic therapies, biologic therapies, maybe even phototherapy that they've used in the past. Anything else?
No, I think my only add is just remember that it's not your hand, it's actually the patient's hand that is the 1%. And so when I'm capturing body surface area, I usually say, okay, now I'm gonna get really, really quiet. I want you to raise your hand up in the air so I can see your hand, and I'm gonna actually count how many times I could fill your hand with the rash on your body or the depigmentation on your body if we were talking about vitiligo. And then I get really quiet and I go around and I count. And then that's the note that actually gets relayed to my assistant to put into the note for a body surface.
I think it's just these little small tips and tricks. Sometimes there are AI, modules that are reviewing our notes. Sometimes it's not even a human being. And even if it is a human being, they may have zero dermatologic knowledge and not know the nuances of different disease states. So whatever documentation we can put in our notes to try to get the best access for medication for our patients, we need to jump through those hoops.
Our patients like to help too. So one of the things my MAs have gotten in the habit of doing is after I've left, they'll actually say, okay, I want to get some pictures today. Show me your worst part. Show me your worst rash. And the patients will really get excited about this. And they, okay, no, it's right here. And they show you where they have the worst rash, and then you can capture that. And if by chance you end up on the phone with, say, a representative from said insurance company, you can say, I'd like to send you some pictures. I'd like to show you some pictures of this rash, and it's really, really important that this therapy gets approved.
Talk quickly about getting on the phone and doing a peer-to-peer review. I think that's something that a lot of providers, especially maybe a lot of the newer APPs that are treating AD and their patients, may be incredibly intimidated by. You may not think that you are, able to do that or qualified to do that. Just how easy is it, and what are some tips and tricks for making that phone call?
I love that you asked that question. The bottom line is we need to be our patients' advocates first and foremost. And though none of us want to spend our lunch break on the phone waiting to speak to somebody who's a peer reviewer, there are a few little tips that I have. And I think first and foremost, when you're scheduling that peer review, ask for a quote, like peer review. In essence, what I'm asking for is another APP to be on the other end of that phone. You would be surprised how often it's, say, a pharmacist or a primary care provider or someone who has no knowledge of the specialty information that's in your head about this disease called atopic dermatitis. And the bottom line is ask them what their specialty is when they get on the phone, and then just explain. This is a patient. They meet criteria by label. This is at least a patient of this age. This is a patient that has this much effective treatable body surface, and these are the prior tries and fails, and I'm not quite certain why you're not approving this therapy. And just in case you'd like, I actually have some pictures for you to review of the extent of this patient's disease.
I love that you pull up the pictures because they are worth 1,000 words, and you are able to send in those photos to really paint the picture of how much your patient is suffering. Don't forget to make sure you drive home itch, sleepless nights, loss of school days, loss of work days. Like, bring in those PROs, those patient-reported outcomes, if you capture them in your practice, and just how much this is affecting the patient's life.
So true. Great information.
Excellent. Well, I hope everyone learned a little something today, and hopefully you can feel our passion for access, and I hope you bring that back to your practice and help your patients get some better outcomes for atopic dermatitis.